Good afternoon and welcome to one of our afternoon sessions. Thank you for joining us. My name is Susan Apkon. I'm a pediatric rehabilitation physician at Children's Hospital Colorado and University of Colorado School of Medicine. And it is a great pleasure to be facilitating this panel. It's easy for me. I just get to kind of hang out, sort of MC it, and let the three very bright women to my left actually do the heavy lifting. The first thing I'm going to do, which may feel a little bit crazy, is I'm going to actually right now change the title of this presentation. So bear with me. Exercise, How Much is Too Much is a great title. I want to change it, though, just slightly, or maybe more radically, to Exercise is Medicine. And I want you to sit with that title for a minute. Exercise is medicine. On Wednesday and Thursday, so Wednesday afternoon, Thursday morning, I had the privilege of sitting in one of the conference rooms down the hall with a group of incredibly bright and engaging physical therapists. And I think there was one or two occupational therapists there as well. They were from across the country, many of whom you may actually recognize as caregivers in your multidisciplinary clinics. The focus of the meeting was kind of a pre-conference, was to help us understand the impact that exercise can have on people with Duchenne muscular dystrophy. Two of the three speakers are here today. Dr. Claudia Senesac and Dr. Tanja Taivassalo, both from University of Florida in Gainesville. And they were joined by one of their colleagues, Dr. Tina Duong from Stanford. And the three of them, actually a fourth person, we had a fourth person join us as well. And the four of them really helped me as a rehabilitation physician understand the importance of exercise. And my hope today is that we'll be able to impart some of that wisdom on you. Our third speaker today is Dr. Renata Shih from the Rare Disease Research Group, also out of Florida. And she is an expert in cardiology, so heart muscle function. And so she too is going to be joining this conversation. You know, when we put together a presentation like this, we come up with some objectives. And really, the way I like to phrase that is, if we are successful, and actually, more importantly, if they are successful, so the onus is on the three of you, if they are successful, the way that you think about exercise, so when someone in clinic is talking about exercise in the context of your sons or grandsons or maybe daughters, that you will think about exercise in a different way. Again, going back to this idea that exercise is medicine. We've heard a lot about lots of different medicines, some that are FDA approved this week, some that are in clinical trials. And what you're going to hear today is the incredible impact that exercise can have also on people with Duchenne dystrophy. We're also going to talk about sort of that practical application. How do you actually implement an exercise program? And I look to you, Claudia, in terms of some of that, and to you, Tanja, as well. So before I invite our first speaker up, I also want to just recap a survey that was done just before this session started. So at the end of the last session, Eric Camino had put up one of these poll everywheres and asked some questions. So I just want to share a couple of those results because I think it's relevant to the conversations that these three women are going to have with us today. So the first question was, how comfortable are you at managing your child's activity? Only about 10% said they are extremely confident that I can do this. 33% said they were mostly confident, so I think I can do this. And over half said that they were somewhat confident in managing their activity. So yeah, I kind of think I can do this. So our hope is that we can bump those numbers up. We asked the question, do you think it's safe for a person with Duchenne to exercise? About 10% said yes, all amounts of exercise are good, and then about 90% said that some amounts are safe. And that final question was, have you received guidance on safe exercise from your care team or PT? And 75% said yes, which was nice to hear. 13% no, and 13% said they were unsure. So my hope is for those of you in this room today, again, if we hit our objective, if we're successful in this presentation, that 100% will say, yes, we have received some guidance from people who are experts in Duchenne muscular dystrophy around on how to implement a safe exercise program. So with that, I'm going to invite Tanja to the podium.
Thank you, and I'm really excited to be here today talking about truly one of my most favorite topics, which is exercise. So I'm going to talk about why it's so important that we do exercise, what we know about exercise in DMD today, and then I'll finish with some, I think, really exciting results from a small pilot study that we've just concluded doing exercise training in boys with DMD. So, as Susan mentioned, exercise is medicine. This is actually a slogan or a global initiative that was launched by the American College of Sports Medicine back in 2007 to really promote the importance of exercise in preventing, reducing, treating, and managing diseases that impact health and quality of life. There is decades of research that have shown that exercise benefits nearly every organ system in our body. So we can talk about cardiometabolic tissues such as skeletal muscle, adipose tissue, endocrine system, the cardiovascular system. We know that exercise benefits gut health, bone density, it improves our immune system, and it even improves cognitive function and the nervous system. And the way that exercise communicates these benefits is through the release of factors from these tissues into the bloodstream during or after exercise that then promote adaptations within those tissues to improve their function. So we know that if we regularly exercise, we will have improved health span, increased longevity, increased resilience. And this comes about through a promotion of good metabolism, a reduction in systemic inflammation, and a reduction in the prevalence of developing comorbidities such as cardiovascular disease, developing cancer, diabetes, and there's a list of different diseases that exercise impacts beneficially. So knowing all of this, it's our duty to study and promote the potential of exercise as medicine for Duchenne muscular dystrophy. And so with that, we'll start, or continue, I would rather say, by just showing you really what happens in our bodies when we do a single bout of exercise. So dynamic exercises such as walking, swimming, cycling. There's a coordinated functioning of the ventilatory system, the cardiac system, and the muscle metabolic system to increase the transport of oxygen from the air that we breathe to the mitochondria in the muscles that are exercising to produce ATP or energy for that activity. So you can think of these systems much like gears of a bicycle. And if there's an impairment or malfunction in one of those gears, you're going to have a disruption in the flow of oxygen, and you're going to see this as intolerance to exercise or physical activity. And there are various diseases or disorders that we know that have limitations or impairments in one of those gears, and certainly DMD we know we have impairment in skeletal muscle, which includes the respiratory muscles. And so this affects these systems upstream from the muscle. In terms of ventilation, we tend to see boys have a hyperventilatory response to exercise. And it also affects their heart, as we'll talk about. And so when we think about therapeutics that are developing or the current ones, we really want to make sure that they also impact the ability of these systems to function properly and transport oxygen to create ATP or energy. So The application of exercise has been very limited to this date in DMD, and that's largely due to these long-standing clinical concerns that exercise might worsen the actual muscle condition. Because of the increased fragility of the sarcolemma during muscle contraction, we might get more damage. And while this is certainly true for certain types of exercise, it is not true for all types of exercise. We know that eccentric exercise or high-intensity exercises may cause damage and should be avoided, as is listed in the current DMD care recommendations. But these recommendations also suggest participation in regular submaximal exercises such as cycling and swimming. And despite these recommendations, there's still some apprehension about exercise in the DMD community. And I think this is a result in large part due to the lack of, well, first of all, misconceptions of exercise and the lack of appropriate guidelines for exercise. What is the appropriate dose of exercise that is safe? And much like we take the appropriate dose of medicine, we need to have an appropriate dose of exercise. Muscles and our bodies respond to a certain amount of overload for adaptation. If that load is not enough, too little, we don't get those improvements in muscle health, for example. And likewise, if you go to the opposite end, if it's too much, we will have injury. So what is that optimal dose? And that's really what we're working on. Not all exercise is the same. So I mentioned earlier eccentric exercise. This is when our muscles are contracting as they're lengthening, and these are the types of movements that muscles will experience if you're trying to brake or slow down. For example, jumping on a treadmill. When you stop the jumping, that's an eccentric contraction on your quads, and that should be something that's avoided. But there are other types of contractions. We have a concentric contraction. That's when you're doing a bicep curl, for example. The muscle is shortening as it's generating force. Or an isometric contraction, generation of force where the muscle is not changing length. And I'll talk about that in the next slide. In order for us to gain adaptations, the muscle has to face overload, as I mentioned. And if we have a muscle that undergoes high intensity, lower frequency contractions, there will be adaptations that occur in the muscle that make the muscle bigger, hypertrophy the muscle, and that's what we get with strength training. Conversely, if we have a muscle that is subject to higher frequency, lower intensity contractions, will induce pathways that make that muscle much more oxidative, capable of generating ATP oxidatively through increases in more mitochondria, more capillaries, and this is also seen as a reduction in heart rate during exercise, as we'll talk about. So in order to get these adaptations safely, there is a framework for how exercise is prescribed. And this framework is built upon something called the FIT principle, which really simply has 4 main components to it. And these components are F for frequency, how often you should exercise per week, I for intensity, how intense it should be done, T for time, and the other T for type of exercise. And there are different FIT guidelines or factors for aerobic training and different ones for strength training. We've also developed different exercise prescriptions based on these FIT factors for different clinical conditions. So shown here are some FIT factors for exercise training in children. There are other FIT factors or exercise prescriptions that exist for cancer, for cardiovascular disease. And we don't yet have those guidelines or factors for the muscular dystrophies, and that's something that we are working to achieve. So I'm going to skip now to a few studies that have been done. This is one that was done by our colleague Donovan Lott, looking at the safety and efficacy of isometric exercise, where the muscles are not changing length. And here, what we did, I've just listed the FIT factors up there, but the important point here is that we did not see any evidence of muscle damage, as seen by changes in creatine kinase, which we measured. And we also had no changes in MRI factors that we looked at, muscle safety factors. What we did find was increase in muscle strength in both the knee extensors and the knee flexors, and this was associated with an improvement in the time to ascend and descend 4 stairs. So these are really notable because it shows us that muscles can adapt to the appropriate stimulus. I'll briefly show, this is the first study that looked at an aerobic training type of paradigm where they used this motorized ergometer. And the main results from this are just that they didn't see any damage and that exercise-assisted cycling may actually delay functional deterioration. Unfortunately, we don't know how much exercise these patients actually did because this motor was completely motorized. And so whether they were doing passive or active cycling was not clear. But we have, since that study, completed another study of 6 months in boys with DMD, and these are the fit factors that we've used, and really they're based on fit factors that we took from clinical populations that have deconditioning. So nothing novel or new here. We had them train 3 times a week at an intensity, and this is really the important component, is intensity, that corresponded to 40 to 60% of their heart rate reserve. All that means is what is the difference between your resting heart rate and your peak predicted maximal heart rate, and then 40 to 60% of that. We had the boys train from 15 to 30 minutes, either in interval bouts or continuously. And these boys did this active cycling using this Rift and tricycle, which you might have seen outside in the hallway. My video unfortunately doesn't work, but it does show one of our boys doing the training. He could only do 2 minutes of training within his prescribed heart rate zone when we started. And this is at the 6-month time point. Unfortunately, you don't see him, but he's actually now not in a stationary mode, but he's biking on this pathway. And he's able to do 15 to 30 minutes continuously in this heart rate zone after 6 months of training. And shown here are just some of our results from this study of 6 boys. We had improvements, significant improvements. Aerobic capacity, so that ability to utilize oxygen improved. The size of the quadriceps muscles, the main muscles driving the bike training, increased as a result of the training. We had increases in bone density of the spine, and this is really notable because all of these boys were on steroids. Again, this is notable, showing that we are impacting other systems, not just skeletal muscle or the heart. We saw improvements in the metabolic profile in circulating factors in the blood. There was a reduction in free fatty acids in the blood, and this is another very desirable and normal adaptation to aerobic training that we're seeing in these boys. And all of these benefits came without any increase in CK and without any change in inflammation in the muscle as detected through MRI. This is just an example of the exercise paradigm we're using. We're using this Riften adaptive tricycle. It's an adaptive tricycle, but it's not motorized. The motorization comes completely from the boys powering these cycles themselves. And we also used a Garmin GPS device, which allows us really to get some more information about how they're training. And we use a heart rate monitor, a chest strap, that then displays the heart rate on the Garmin GPS. And then we get a bunch of information. The parents then upload the training session onto the Garmin portal, and then we can see exactly where they've ridden their bicycle, either outdoors or stationary inside. And we also get all the information on their heart rate, their respiration rate, how quickly or what the cadence was, and how far they cycled. And this is something we've implemented in the last year or so. And I just want to finish by showing some other results from one of our participants from the 6-month training study. He experienced so many great benefits as a result of the training that he wanted to continue training. And he's still training to this day. It's been over 2 years that he's been on his bike. And this is just some data that I show from since we've started collecting the Garmin data. And you can see here that he's been cycling diligently in his prescribed heart rate zone between about 140 and 155 beats per minute. He has cycled a total of 325 miles this past year, about 9 hours per month, and he's expended about 250 calories per session over the year. So these are quite remarkable results in my mind. And we've also looked at his MRI. Again, we're very interested to know what's happening with respect to the pathophysiology. And this is just a Dixon image showing the accumulation of fat. Within those 2 years, he had a slight increase in fat fraction, but nothing that was out of the ordinary. It was actually smaller than what you would expect for 2 years. We're also concerned with the impact on the heart. And we did see some real benefits in cardiac function in terms of heart rate. So their heart rates are much lower at a given level of exercise after training, showing this improved efficiency with result of training. We also saw no changes in his echo, and his ejection fraction was normal. And we've recently implemented cardiac MRI to look at cardiac function, and he has normal cardiac function both through our research MRI, and this is his recent clinical MRI that was done. I'm showing his clinical report. Highlighted in yellow is that he's got normal left ventricular function and volumes and no evidence of fibrosis after 2 years of training. So we don't have a baseline cardiac MRI, but at a minimum we can say that we haven't hurt his heart in any way as a result of this training. So our takeaways, exercise intolerance in DMD, as in many other disorders, is due to inefficient, to muscle limitations, as well as abnormal cardiorespiratory responses to physical activity. But we can improve those responses through exercise training. And exercise needs to be included in the list of prescribed medications, just as it is for cardiac meds, steroids. We need to include exercise, and we need to prioritize exercise in the regimen. The dose of exercise is important, finding that therapeutic dose. Of course, all patients should have a complete cardiac workup before starting exercise, we're seeing evidence of these multi-system benefits. And I'll just conclude by saying we need to consider exercise in all of our other therapeutic trials, looking at it as an adjuvant. And with that, I will conclude. 1 minute late, sorry. Thank you.
Thank you, Tanja. That was fantastic. You know, as a physician, that FIT principle made just a ton of sense, right? So if someone comes to me and has an ear infection, I say you need to take amoxicillin, 250 milligrams twice a day for the next 5 days, and I know that that will decrease their, it'll get rid of their ear infection. And so those principles that you shared, super helpful for me as I think about working with our physios to prescribe something. So thank you. So Dr. Shih, welcome you to that podium.
Hello, good afternoon. It's hard to follow Tanja. I am a cardiologist, so my talk is much simpler than the one that she did right now. I'm a pediatric heart failure and heart transplant doc. I have been working with neuromuscular for 10 years. I met Tanja during my time at University of Florida, and I have been involved in exercise training in Duchenne's muscular dystrophy since. I would like to thank PPMD for the opportunity to participate in this panel and talk about the effects of exercise in the hearts of DMD patients. I don't have any financial disclosures. And I wanted to start just to talk about what are the changes that happen in your heart in a sedentary person. So this is me trying to run a Star Wars 10K once a year that I do, and what happened with my heart. So when I start running, my muscles, they demand more oxygen. So my heart is gonna need just to beat to beat faster, to send the blood volume that is in my heart. This is called the stroke volume. And the heart rate plus the stroke volume is going to give our cardiac output, this amount of blood volume per minute that is sent to our body. And we increase the cardiac output, is going to increase the flow through the vessels, so it's going to increase our blood pressure. And this is mediated by our sympathetic and parasympathetic systems. So now, what happened with someone that really trained almost every day, like Tanja? This is her by the end of her 10K. You guys can see the difference in stamina when she just completed, in fact, with her 86-year-old dad recently. So what happened with the heart is that the heart gets bigger, so we get what we call the hypertrophy, athlete's heart, with increased production of energy by the mitochondria. So since the heart can eject more blood flow and more effectively, so increasing our cardiac output, the heart rate is just decreased. And since the blood flows slower through the vessels, it's going to allow better extraction of oxygen from the muscles. So now, what happened with the heart of muscular dystrophy patients? So by the natural history studies, we know that somewhere in between 6 to 10 years old, starting happen the fibrofatty infiltration. There's not that much loss of cardiomyocytes by that time, so that's why there's some hypertrophy. And as disease progresses, there's loss of those cardiomyocytes, and the heart starting getting bigger, and the function starting decreasing. Oops, sorry. So what do we know when DMD patients, they do exercise? So this quote came to my mind. There are known knowns. There are things we know. We also know there are known unknowns. That is to say, we know there are some things we do not know, but there are also unknowns. The ones we don't know. So what do we know? So this group in New Zealand, they wanted just to see how the heart of DMD patients behave during exercise. They picked up 11 DMD patients and 11 non-DMD patients from 8 to 14 years old, and they asked for them to exercise in the MRI machine. And what they observed is that DMD patients, they have a lower heart function. Is still normal. Anything above 55 is normal, but it was lower. But their rest heart rate, it was higher. And when they went to do exercise, they reached almost the same peak of the non-DMD patients, showing less augmentation of when the body demands more. The other things that you observe is that ESV stands for end systolic volume, meaning it's the volume of the heart when it contracts. EDV for end diastolic volume, this is the size of the heart when it's completely filled. And their difference is the amount of volume that the heart sends it when it contracts. So what they observe is that at rest, this is the amount of volume that is DMD patients send, and this is the amount of volume non-DMD. And when the body demands more due to physical activities, this is that much that DMD patients, they increase, and this is the amount of non-DMD patients, just showing that they have a lower ability to increase the cardiac output from rest to exercise. They also observed that the LV mass, the size of the heart, was already bigger on those patients, and that they got into the conclusion that exercise can already do an early diagnosis of cardiomyopathy, even in patients who has normal cardiac function. But what do we know when those patients, they do regular physical activities, exercise training? Unfortunately, there is nothing published yet, but there's studies already. There was studies in animals. So this group from the Netherlands, they studied the mice. They wanted just to see if exercise can modify the course of disease in older mice, meaning the mice that already had fibrosis in their muscles. So they picked up 15-month-old mice, and they divided in two groups. One, the sedentary one, the one that's called voluntary exercise. On the voluntary exercise, they put a spinning wheel inside their cages 3 times per week for 2 months. And after 2 months, they checked those mice, and they saw that the mice who voluntarily exercise, in fact, they have more dystrophin in their quadriceps. But in the heart, there was no difference regarding the dystrophin, the amount of fibrosis, the size of the heart, but despite of that, they have a better cardiac output. Oops, sorry. It's not going forward. Oh, sorry there. So Dr. McNally group did the next step. So they picked up younger mice around like 4 months old, and they divided in 3 groups: the sedentary, low intensity, and moderate intensity exercise. They exercised those mice 3 times per week for 6 months. And what they saw is that those mice, they have increased force and they have slower muscle fatigue. And from the cardiac standpoint, they saw that they have a slower progression of the LV dilation. They have a slower progression, they decrease the cardiac function, and slower progression of the thickness of the heart. And the other important thing that they observed is that those patients, they did not have increase of fibrosis in their heart and diaphragm or gastrocnemius. So getting all this data, plus the data that Tanja just presented, we believe that it's like low to moderate exercise does not seem to worsen the cardiac function. In fact, the exercise might have some benefits of the heart, but of course, more studies are needed to establish the exercise prescription, especially in the light of recent advanced therapies for DMD. Sorry. So my kids always tell me, Mommy, if you continue showing Snoopy, they know how old you are. I say, yes, I'm old and like Snoopy. But they have good codes. So to strengthen the muscles of the heart, the best exercise is lifting someone's spirits. And in that light, I want to just thank like PPMD and all DMD patients and their families for your continued support. You guys are the force that drive us to do better and be better. Thank you.
Thank you so much, Dr. Shih. That was amazing. I think, one of the questions I get in clinic a lot is around safety. And so I think, Tanja, you talked about the safety at the muscle level, skeletal muscle. You did a lot of MRIs. And I think from what I'm taking from your talk is so important that safety at the heart level, we have some safety data to suggest that it is a safe proposition to get someone involved. So I look forward to maybe some other questions around that from the audience. So, and with that, Claudia, you want to join us at the podium?
Good afternoon. So what I really wanted to focus on is how do you work with your therapist about exercise. So exercise, what is it and what should you do? So exercise is movement, and that can take on a multitude of, it can look very different depending on the person and their abilities. Movement is healthy, and it's healthy for not only your body, but it's healthy for your mind and your overall health. Healthy body and mind and the ability to emotionally regulate empowers people. And so exercise can help with that. How will you know what exercise to do? And that's really a big question. We've heard from Tanja and from Renata how, exercise is changing now. We have a lot more options available, and that's a good thing, because it used to be in Duchenne and in Becker that what we had to offer was stretching and flexibility. And now we have, the landscape is changing, the paradigm is changing. And so what can you do as a parent or an individual that is seeking to exercise? So you need to educate yourself. You need to know what the benefits of exercise are and to be able to articulate that to a therapist where you're going to exercise. And then again, you need to know what the red flags are. What are the warning signs? Because not everyone that you go to will have all of this information. And so part of seeking out resources or services is that it's a collaborative effort. Do your research. And that is going to take some time, right? I mean, you're sitting in this room and you're listening to us, and that's part of doing the research. That's part of figuring out what's new, what's changed, what can I do about it for my child, what can I do about it if it's for me personally. What is considered reasonable and under what conditions? And Tanja spoke to that. Renata also mentioned some of that. You need to dig into that and find out what are those parameters, because not every therapist right now will know that. And it doesn't mean you're going to tell the therapist what to do, but our last couple of things on here is make those connections. We don't expect you to go into the therapist and say, this is what you should do with my child, and here are the parameters. But make connections with people that do know those details. Therapists that know about dystrophinopathies and these current exercise parameters. And maybe you say, well, I don't know who those people are, but some of those people are us, and some of those people are sitting in the audience listening to this. And if you get home and you go, I don't know how to contact those people, you can contact Parent Project, and they will put you in touch with us and with other individuals that know what those parameters are. And we are absolutely willing to talk with a therapist that you are working with. It's really important to ask questions when you go in to work with a therapist. It's okay to say, have you ever worked with someone that has a dystrophinopathy? Have you ever worked with anyone that has Duchenne? Have you worked with anyone that has Becker muscular dystrophy? It's fine to ask those questions because you want to know. You want to know what kind of care you're going to be getting and what your child is going to be getting. You and your therapist need to work as a team. You need to discuss the plan together. It shouldn't be that the therapist tells you the plan. You need to work together to discover and determine what plan works best for you individually or your family. Because I know if I give you an exercise and I don't talk to you about some of the nitty-gritty about your family and your routines, it may not happen. So you need to really work together. You are part of the team. You're the main player on the team. So you want a therapist that's willing to actually have those discussions with you instead of just saying, here's your therapy program. And then what do you talk to the therapist about? So there are quite a few things on here. And I think both of the previous speakers spoke to this. You want to check with your physician first. You want to get clearance, particularly from the cardiologist, that the heart is healthy enough to be exercising. That's going to be really important. And then what are your goals? Why are you going to therapy? Sometimes people show up in the office and I say, you know, what brought you into therapy? I was told I need to come to therapy, or I need to bring my child to therapy. And then they're not sure why they're there. So figure out why you're going to therapy, what your goals are, what you might want for your child if your child is coming and they're very young, or if they're a little bit older. You know, motivation plays a big part in therapy. It's really hard to make people do things they don't want to do, to make progress with it. Figure out your routines. Figure out, how will I fit exercise into the routine that I already have? Because people are busy, right? I mean, you're getting up in the morning, you've got to get breakfast ready, you've got to get the kids ready to go to school, you've got to maybe drive them somewhere, maybe you're homeschooling, maybe you're working on top of it. You've got to figure out where these exercises will fit into your daily life, because you won't get better unless you can do the exercise, and you can't do the exercise unless you can fit it into your routine. And then, is your therapist willing to collaborate and to reach out if they're not sure what to do, or if they're not sure how to progress the exercise program? And that's really important. You don't want to go to therapy and have them just pull something off the shelf and say, this is what we do for Duchenne. This is what we do for Becker. Every person is an individual that comes in for therapy. And so that means we cannot treat each patient the same. I need to be able to assess what each individual's needs are. And they may not fit that piece of paper that comes down off the shelf. So you need to make sure that you've got a team player that you're working with, that if you run into some difficulty or they don't have all the updated information, this is fairly new information, so we don't expect everyone to have this information. Are they willing to talk to another therapist or to another resource and collaborate and learn more about it? And then that nitty-gritty that I was talking about are all of these things that are listed below. You want to be able to share this with the therapist, and they should be interested in it because it will make a difference in how they put together your exercise program or the exercise program for your child. Who is your care team? Who are the members of the care team? How do I get in touch with them if I want to find out some more information? What's the family situation like? Is this, are both parents in the home? Is it a separated family and the child goes between two homes? Medications, what medications are you on? Are you on supplements? Do you think they're working? Is there pain? What does this person do in their leisure time? Very important. And then hydration, diet. If you're exercising, you need some protein. We're not nutritionalists, but we do know something about diet and how it affects exercise and the outcome of exercise. What about sleeping? Does the child sleep through the night? What position are they in? Do they have pain? Are they restless? Are they up and down through the night? Are they in a research study? Are they in a natural history study? Do they have cramping? Where is it? Typically, it might be in hands, it might be in feet, it might be in their calves. What brings it on? These are the kinds of questions you want your therapist to ask, but they might not if they don't know a lot about dystrophinopathies. So share this information. Are they on non-invasive ventilation at night? And then what about fatigue? What brings fatigue on? How long does it last? Those kinds of things. And then remember to tell your therapist, not all muscular dystrophies are the same. Not every individual with the same diagnosis will present in the same way. Again, going back to your exercise program should not look like your friend's exercise program. They should be individualized. You or your child want to do something that's enjoyable. It should be fun. It shouldn't be torture, and it shouldn't be, if your child goes, "Oh, I don't want to do that," it's not fun. So you want something that's going to be enjoyable to do. Exercise to exhaustion is a complete no-no. That means you've completely overdone it and you're going to end up in a bad situation. And you can provide resources to them. You have a great resource here with Parent Project Muscular Dystrophy, and they can guide you to other outside resources. And then just finishing up, benefits of exercise. We've mentioned a lot of them, and it's a long list. Exercise is medicine. It makes people feel good. It improves your circulation. It makes you feel more relaxed. It improves flexibility. It may help you breathe deeper, sleep better, be more alert, improve memory and attention. Gives you a feeling of accomplishment. You feel happy after you've exercised. Talking and engaging more, increased appetite. Exercise can lower your blood pressure if that's a situation that might be relevant to a person who's exercising. It can increase endurance, decrease fatigue, possibility of increased strength, and improved emotional regulation. And then there are red flags, which you need to know about. And I am beating the clock here. It's so crazy to have this clock here. But these are important. Increased fatigue after exercise, and it doesn't mean immediately after exercise. It means the next day. If you can't get off the couch because you exercised the day before, you've done too much. Increased muscle, joint, and back pain, you've done too much. Muscle soreness greater than 24 hours after exercise, you've overdone it. We expect some muscle soreness, but you shouldn't have it greater than 24 hours. Dark, tea-colored, or red urine. That is a serious sign of a condition called rhabdomyolysis, and you need to seek medical help. You should be calling the physician. If you can't reach the physician, you should go to the emergency room. Difficulty sleeping, restlessness, shortness of breath that lasts longer than a couple of minutes after exercise, tachycardia, which is a rapid heartbeat that does not resolve when exercise is over, and then low or high blood pressure that's out of the ordinary. I did it. Okay.
You did it, Claudia, and you did a fabulous job. And I so appreciate that practical recommendations. So thank you for that. And with that, we have 11 minutes, I'm told, to take questions from the audience. So I'm going to welcome people up to the podiums. I think they're in the sort of the aisles. Oh, we've got one right over here.
Hi.
Hello.
I have a quick question. My son, Leon, is 11, and he has a trike, an electric one, and he goes out with his trike. And I love what you said, Claudia, about exercise being fun. And I feel like exercise is also a way that they connect and socialize. So I'm happy that this is being said, because sports, of course, they can do them unless they are adapted. So I think it's a great idea. I do have a question, because it feels like because of what Tanja said and Dr. Shih said, it feels like the exercise that you guys are suggesting has to be kind of controlled. Is that what you mean? Is it okay for him to go out on a bike ride? It should be considered the heart rate or some other considerations, like as parents, that we can do?
Hi. I think all of us might have a quick comment on that. So I think, your child should have fun, but there's also a place for the more regimented, structured exercise if we want to try to improve some of these pathophysiological changes that are inherent to DMD. And that's really what we're researching with these regimented heart rate zones. We don't want them exceeding these zones. We're trying to find a moderate, we're trying to find the right dose that they can get those benefits, which we know will also make them happy and have fun, but certainly they don't have to always exercise in the zone.
Go ahead. And what I was going to say is that even, it's like you let him do whatever he wanted, how much he wanted. Usually it's not that amount of intensity that we are referring to. It's like when we do the exercise stress test or when we do high intensity, it is by the point that, oh my God, I cannot do this anymore. So usually the kids, when we let them play at their leisure, they don't reach that point, sustained point for long and very frequently that either.
And just to go back to what Tanja said, is that he's doing a leisure activity that's really fun and it's exercise and it's great for him. Some of this more controlled exercise that Tanja has been talking about is looking at, if I want to increase his endurance, if I want to increase strength, then I need a more regimented training to do those kinds of things. If you're looking for I just want him to have fun, I want him to get some exercise, this is good for his heart as well, and it's good for his muscles, and it's good for maintaining, sustaining, flexibility in his body and the socialization. That's a good plan for him.
Great. Thank you for that question, Maru. Right here in the middle.
All right. Hello. I have something very similar to her question. As parents, my son is 14 years old, and we had just been in clinic, and they had suggested that we start him on biking, stationary bike, about 15 minutes every day, kind of like what you were saying. But then I'm seeing this intensity thing, and I'm like, how do I know how intense his bike riding should be? Is it too intense? Is it not intense enough? Does it matter?
I think it's going back to the goals that Claudia just said, fun versus kind of trying to improve fatigue, increase endurance. And we need a heart rate monitor. That's kind of the safest and really most effective way, in my mind, just to monitor that intensity and keep it moderate. And maybe we can put something up on PPMD in terms of how to do that for heart rate, but they're easy equations.
Another thing is that when I follow a lot of the exercise that she does on the DMD participants, and for them to reach this amount of intensity, it's like we need just to push them and increase the watts of the bike. At their leisure, believe me, they're not going to do that. They don't want to do that. They make the effort because we are there cheering and everything like that, but it's a lot for them. So if he wants just to go at their leisure, it's fine. Another thing that we do before they starting doing the regimen or exercise is that making sure AKG is okay, the echo is okay. Sometimes we do a Holter to make sure on their regular activities how they are doing. And before prescribing, we recommend just to do a CPAT. So we see when they reach that maximum intensity, how the heart is behaving. So they'll feel more comfortable to how much they can do it because they already saw it. What is the maximum and how his hearts behave.
In many ways, it feels like if I want to exercise, I'll get on my bike and I'll just ride for a period of time. But if I really want to get real benefit, it's working with an athletic trainer, right? So if I want to get maximum sort of benefit strength, for example, sending me to the gym is not going to give me maximum strength without someone coaching me. And in many ways, that's really where our physical therapists can be so, or exercise physiologists can be so instrumental. And I want to say, and we've had this conversation, we had the conversation on Wednesday afternoon, Thursday morning. I think that we, as a kind of a rehab therapy, exercise physiology community, have some work to do. And I think the group at University of Florida is doing it. And I think what we need to do is to get out some very clear recommendations, right? At how do we really teach our physical therapists, rehab physicians, exercise physiologists, how do we teach them to prescribe that fit, right? The frequency, the intensity, the amount of time, and the type. Because I hear other families ask this a very similar question, which is, what is the right amount, and how do we really get the right benefit? So thank you for that question.
Thank you.
Other questions? Please.
Hi. I have a grandson who is 5 years old, and he is starting kindergarten. And he likes to ride a bike to school. The current one is close by, so we go with the ordinary bike, the tricycle. But the new school is about a mile away. So we've been looking at the adaptive bicycles. Do you have any? So if he would want to go every day to school and come back by bike.
So I think it's possible to get to that point. Again, we would need to kind of progress slowly and get him to be able to ride a mile. But certainly with the research we've done with the tricycles we've been using by Riften, our boys are able to ride over a mile, 3 miles, again, with slow progressive increases in the amount of time that they spend in their prescribed heart rate zone. They can get there.
So one of the bicycles you showed had a heart rate monitor too, right?
So no, we buy that separately, so you can get heart rate monitors,
Okay.
and we just use it while you're exercising on the bike.
Okay.
I think, adding on to that, just to be a little bit more specific, if you're looking at this for the fall, then you start working now on building up, in small increments. If he rode to school last year, what was that distance? Then you have that distance in your mind, he can do that. And then you add a little bit each time, maybe 1/10 of a mile to add on to that. And you're with him so that if he's fatigued, he's off the bike. And so you're gradually building up so that you get to that mile, but it has to be slow. This is a slow, low resistance, slow progression so that everything adapts in a slow manner, and you're not overstressing the heart or the muscles for that matter as you're preparing him for this 1 mile ride to school.
So would a stationary bike be better then, because then it's at home and you can monitor it more closely? He does enjoy riding his bike outside. So that's one of the reasons we were thinking about it.
So I think there's, again, benefits of both, but there are some bikes that do both. So the ones that we have here by Riften, that comes with a stationary stand, so you can use it inside and do your biking, or you can go outside easily. So kind of, I like the option of doing both.
I'm going to add a slightly different approach to this. I'm looking at Alexis because they always talk about how I'm a pretty practical person. If your family's goal, your grandson's goal is to bike with the other kids and have fun and get to school, I see that as a different goal than exercise. So the way I might think about that going from home to school is more about fun. And so putting a power assist on that bicycle or getting a power assist bike, using the bike riding for exercise as a different, sort of at a different time, because I also want to make sure that when he gets to school, he is well rested so that he can focus on his learning. And I sometimes worry that I prescribe, exercise, and it's done in a way that might actually have a negative impact on other aspects of life. And so just a different way of thinking about it that you could consider. I'm looking at the time, and I don't see anyone else at the microphone. So I'm going to go ahead and take this opportunity to wrap up.
Can I make just one
please,
more comment? Just
please.
one more thing that popped into my head, or maybe two. One is that we're also wanting to consider exercise options for non-ambulatory boys. And so we are working or looking for ergometers where they can do actually arm pedaling and leg pedaling to now get those benefits in the upper body as well, but also cardiovascularly. But in our kind of experience with our patient who continued training, in the course of this 2-year period of training, he's stopped walking, and he's still riding 3 miles on his tricycle and happy. And so as a result of that, we've actually had a couple other boys come into our lab who are non-ambulatory, and they've been able to ride this bicycle with their legs. Just, down the hallway. But again, if we started earlier training them, the potential is really there. And so it's just opened up a whole new world, I think, for where we need to go and what we need to still figure out. And we're just starting right now with these guidelines, but I think we're going good places.
Tanya, that was an incredibly important point. I remember you shared on Wednesday and Thursday, that story, and I think in my mind, I was thinking ambulatory boys, but that story of a child who has lost ambulation and is still pedaling 3 miles a day and improving is fantastic. So I'm looking at a couple people. It looks like we are going to have to wrap this session. We'll be available to answer questions, but I want to bring us back to the original objective, which was, my hope was for people my hope was to be able to convince you or have them convince you that exercise is medicine and the importance of exercise in your child's or grandchild's treatment plan. My objective also was to have this be a practical sort of session with some really important recommendations from all 3 of you, so thank you for that. I think you all hit that target. The charge that I think that we all have as a community of exercise physiologists, physical therapists, rehab physicians is now to really push this out to the broader Duchenne community. And so I think I look to our colleagues in University of Florida who have just done tremendous work, and I think stay tuned for the ongoing recommendations that come from that group. The final thing I want to say is I think, and Tanya, you said this, I think this is the first podium presentation, I'm roughly counting a couple hundred people here, of a focus on exercise. And I think that really highlights the importance of exercise in, again, this overall treatment plan. So with that, thank you very much for attending. Again, thank you very much to our panelists.